Hello, good evening, good day, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a cardiac surgeon in Yorkshire in the United Kingdom and the director of the Faculty of Surgical Trainers for the Royal College of Surgeons of Edinburgh and a visiting professor at Imperial College. I'm extremely grateful to the 3,094 followers across the globe who are tuning in regularly to watch the Black Belt Academy of Surgical Skills. And I'm very grateful to Dr. Hadia in Pakistan, who sent me pictures of him stitching a banana. Indeed, social media has been alive with pictures of people stitching tomatoes and grapes of late, and I'm delighted to see the concept of low fidelity practice at home is catching on. There are many things in martial arts that accord with Buddhism and correspond to Zen. In particular, there's repudiation of attachment and avoidance of lingering on anything. This is the most important point. Not lingering is considered quintessential. And it reminds me of a colleague who said, "Go in slow and deliberate and come out quick." And Lord Brock said, "You should not judge a surgeon until you've seen them close a wound." And I recall when I was a senior house officer in Bath back in 1987 that I'd done a nephrectomy, and I was very pleased with myself as one of my first major operations. And on day 4 we looked at the wound, which was a lovely, beautiful, thin red line, and the senior registrar Ken at the time says, "Well done, you did that well." And I said to him, "The wound speaks for itself." At day 5, the wound was a bit red. At day 6, it started to ooze. And by day 7, it had completely fallen apart and dehisced. And according to Ken Hasty, he had never seen a nephrectomy incision dehiss. And that stuck with me forever throughout my career. Because although Lord Brock said you can never judge a surgeon until you see them close, I would say do not judge a surgeon until you see the wound before discharge. And anything less than a perfect wound is a problem for the patient, and I think we should change the conversation. And I was contemplating this evening that maybe we should talk about wound infection. The important point is that all the tissues need to be respected in the same manner as going in and coming out. And all the principles of stitching that we've been teaching you in the Black Belt Academy apply. And it's sad that when it comes to closing, it's regarded as coffee time or hurry up time, and everybody leaves theatre. And usually the most junior person is left to close, with very little in the way of supervision or guidance or instruction on how to tension the sutures and to place the sutures. I was also contemplating that there is very little in the literature at the present moment about drains, and I was going to talk about drains briefly. And drains have been used since time immemorial for pus. We used the knife to lance and release the evil vapours and leave a drain there to allow it to epithelialize up. Drains are now used predominantly if there's a chance of a major bleed. We see this in cardiac surgery, but also major orthopedic surgery and neurosurgery. And the problem is that the major bleeds in those areas could cause compression. But also, the hematoma from a bleed and the thrombin is a potent stimulus for inflammation, pain, scarring, delayed healing, and also wound infection. So, blood. In cardiothoracic surgery, the other reason to use a drain is obviously air leaks and lungs. And sadly, the management of the chest drain is in general poor and the most common cause of complications in thoracic surgery because of poor placement, poor management, poor understanding of a closed system and underwater seal. But most importantly, I think, is that the incision for the drain is not big enough. The suture to close the drain hole is not put in position before the drain is put in. And then when it comes to taking it out, the tension put on the sutures is such, and they're often purse strings, mean that there's necrosis of the skin, and I often look at patients with drain sites that look more like bullet wounds. The next major indication is perhaps in hepatobiliary surgery and major pancreatic surgery. But it's interesting that routine use of drains in clean surgery nowadays is very rare. In exploration of the common bile duct, the T-tube was made of rubber and brought out onto the skin and left there for 7 days to create an artificial fistula to allow the whole thing to heal before being taken out, because fistulas close provided you've relieved the distal obstruction. And all being well, in exploration of the common bile duct, you would have removed the stone. But in major hepatic pancreatic surgery, drains are sometimes left in and are used to test whether there's bilirubin or amylase in the drain as indication of the leak. But drains for major surgery are seldom used. The last reason to use a drain is if there's a large surface area and a risk of a seroma. And we see this predominantly in breast surgery, but there's also a risk of lymph. And drains are used there to hold the tissues together. What's interesting in looking at the literature though, the final statement is that drains are not a good substitute for surgical technique. Surgical technique and attention to care of the tissues trumps everything else. And indeed, drains, in some studies, have increased the risk of wound infection, particularly the open drains that drain to gauzes or stoma bags. Not only is this discomfort for the patient with increased pain, smell, and length of stay, we should be using closed drains because there's less risk of infection and also it's better for the patient. But there's a lot of debate as to whether they reduce wound infection and reduce problems after surgery. And with better surgical technique and radiological intervention, we're probably seeing less drains used today than in previous years, certainly in my era. So let's just look at some basic principles of closing the wounds, and we'll take you to the overhead camera. So, just to show you first, this is the banana that I used to stitch to create the advert for this session. And what I'd like to point out is that the banana gives you a fantastic feedback on your use of sutures. And if we hone in, you will see that each needle mark is clearly demarcated. And what I hope you understand is that I've come in and out at 90 degrees all the way through across the tissue. The other important thing is that I haven't pulled it tight. In fact, these are quite loose, and certainly when closing an abdomen in a paralyzed patient, you should not have tight sutures at all. And the theory is that you need 4 times the length of the wound in the length of suture. In essence, the layers are just held together and juxtaposed. And what you can do to practice this, and why I like the banana, because it's readily available, is put some marks on the banana, and with a needle only, practice coming in and out and lining your needle every time. The thing is, with continuous sutures, people forget as they're going along, frantically trying to stitch and close, they forget to line their needle each and every time. And in losing that alignment, they lose the accuracy of the rotation. But what is worse, they lose the 90 degrees, and the 90 degrees is perfect for eversion. Now, you note that I was not holding the banana edge with these forceps, and these two forceps I've demonstrated before damage, and I actually reflect. And out of respect for my plastic surgical colleagues, the best thing to use is a nerve hook. And the nerve hook to lift the skin up either side and respecting the tissues. But this simple model is extremely useful for reinforcing your needle skills and needle technique. And lifting the edge up, I can now take it 90 degrees from the inside. And you should do that for every single layer, remembering that the distance from the edge, skin of each layer, needs to be such that you leave space for this lag zone of inflammation across the two edges, because that is where at 3 to 4 days, with the pathophysiological process of healing, the increased edema will occur and swelling the tissues and risking increasing the tension. So that is why we should not stitch and bring the tissues together tight, because at 3 to 4 days this lag zone will cause swelling and increase the tension. So let's look at a wound, shall we? And this is the pig wound incision that we used last time, and you can see in the bottom here layers, and every layer needs to be closed accurately and deliberately in the same way you would close a banana. And there are a couple of tricks. One, I hope in making the incision you have undermined the skin so it gives you better access, and therefore do use retraction to ensure that you get to the end of that incision. Two, when putting and securing your sutures inside, is bury the knot. So you note I've started from the deep side, superficial, and coming now superficial deep to take the knot down. And in taking the knot down in this fashion, I'm ensuring that it's buried deep. Now, whether you use a monofilament, which is more inert and less traumatic, but the knots are not secure and handling is worse, but the monofilament causes less chance of infection. Braided filaments and sutures, easier to use, easier to knot, theoretically increase use of wound infection, but this is a bactericidal suture, Vicryl Plus, and therefore I don't think there's much in it. What you do need to understand is how long it takes for each suture to absorb. So for Vicryl it's 60 days, for monocryl 100 days, and PDS for 200 days. And in doing so, then you also need to understand how long it takes for each layer or each tissue to heal. Days for muscles and skin, weeks or months for fascia and tendons, and of course for prosthetic material and vascular material, years, if not forever, and therefore you use a non-absorbable suture. The important thing is that each and every time you do a continuous stitch, you need to remember that that is hemostatic in itself. And if there's any worry about the blood supply to the tissue, it is best avoided as a continuous stitch. The tension of the suture is taken through each and every time. You do not, as I see often, and I'll demonstrate, or really poor closing, people whipping the needle through, taking a number of bites, and then once all their sutures are placed, thinking that they're saving time, they take the suture and watch this. They pull. And you see that is seriously strangulating the tissue, and is very poor technique. Being slow and deliberate all the time is very important. And if there was space in those layers, and I was worried about bleeding, I personally would have no hesitation putting a drain in, mindful of the fact that it's an extra incision through the skin and potentially painful on removal for the patient. So each and every layer should be treated with the same respect. We'll come on to closing the skin, and for this, really, skin suturing is vitally important. Remember, as I said, the patient will be judging you on what the wound looks like. And the best hemostatic but not strangulating stitch to use is a simple interrupted suture. So when it comes to the skin, simple interrupted suture, note that I'm not grabbing it, I'm reflecting. It's taken through the skin. And somebody was asking me, how do I stitch the skin holding the sutures, a needle holder as a benediction sign? Personally, I find it easier to do this and rotate the needle than I do to put my fingers through the rings. And it really depends on your needle holder. So the simple interrupted suture, provided you've come through at 90 degrees and equidistant from the edges, instrument tying is beneficial. One, it's easier, and two, conserve sutures, but to keep one end short, throw the thread twice around the needle holder, pull it down straight, cross it to lock it off to one side, and then complete the knots. Keep them long enough so the knots are secure and you're able to take them out. And really what we should be seeing is the edge everting. So the eversion of the edge starts the way you pick it up. I'm everting the skin, coming through at 90 degrees, delivering my needle carefully, coming through from underneath at 90 degrees, as accurately as possible and opposite. And the suture size, the smaller the better. So I'm using a 3 over here to enable you to see, but I would advocate a 4/0, if not a 5/0. Depending on some parts of the body and face, perhaps a 6/0. And what we should be seeing is eversion of the two edges. If it's not everting very well, to help that eversion, a vertical mattress suture starts further away from the edge, comes and is likewise placed equidistant across the other side from the edge. But now, to assist the eversion, I am going to come back again in the same line and pick up just the very edge. And this vertical mattress suture is quite nice to help you start to evert. See that? It automatically starts everting the skin and makes it easier. But I wouldn't recommend that you use a mattress suture for all the stitches, because it is a strangulation stitch in itself. But I've pulled that, but you can see that the two edges are everted. The most common suture that we use to close is a subcuticular suture, and again, a monofilament is useful because it is inert, less wound infections. But the thing is, with a monofilament, whether it's an absorbable suture or a proline like this, the knot itself that people put in at the end, one, isn't comfortable, and two, is a nidus for biofilm. So I would not recommend knotting your monofilament at all. And what I do is, certainly with a proline, I'd either use a liquor clip there. Sometimes they used to have beads to put on to hold, but I would not put a knot even on a monocrol. So a subcuticular stitch, the 90-degree angle applies as well. Again, I'm not grabbing the skin, I'm just folding it over and coming in the subcuticular area. It requires deliberation and purpose. There's nothing fast about it. And remember, the skin stitch is not going to cover up poor closure of the deep layers. Accurate stitching of each and every layer is vitally important to get good closure of the skin layer. And what I'm trying to demonstrate here is that I'm coming 90 degrees immediately opposite where that's come out in the subcuticular tissue, and to do that I go slightly behind. And what I hope to see is that my suture is running 90 degrees, as you see there, across the wound. And as I pull it together, I've got a nice, clean suture. Now, what is important is that the skin edges come together without overlap. Too often I see people do a subcuticular stitch, do it very quickly, and I'm trying hard. Well, there I've forced a little bit of an overlap. See that? The overlap. I'm trying to force one there for you, where the skin edges are not sitting flush together. I don't think it looks pretty, but more importantly, I think it predisposes to wound infection as well. And the other thing I note is that people do a lot of stitches, pull tight like that, and you end up with this crinkle arrangement. And again, that doesn't look good, and certainly doesn't predispose to a good looking incision. So care and attention should be taken at every stitch, every placement, on every layer. And I suppose Lord Brock was correct. In fact, I would say he's correct. Do not judge a surgeon until you see them close a wound. I find practicing here totally engaging. I find myself getting lost and time is slipping away. But I hope this has made sense to you. I hope we've reinforced some basic principles. And stressed, it all comes back down to technique. What was interesting, my son and I went into a karate competition at the weekend. He came second, I came third. And apparently the difference between first, second and third was a nuance on a hand position and tucking in the thumb. Just imagine if we paid that amount of detail and attention to detail in how we taught surgery. Because in martial arts, you don't practice until you get it right. You practice until you can't get it wrong. And to have a difference between first, second and third, down to a nuance and a position of the hand, well, personally, that drives me to practice more. And I hope the models that we offer in the Black Belt Academy of Surgical Skills inspire you to practice as well. I look forward to seeing your pictures. Do send them in. Do send communications. I hope you're well. Please be safe, and I look forward to seeing you next week. I think I might talk about wound infection. Thank you, good evening, and good day.